So good evening, everyone. And at the outset, I'd like to thank the Panacea team and Dr. Jayant for inviting me for this lecture. As the previous lecturer had said, I'm also an early in my career investigator, so it's quite an honor to be speaking on this topic. The topic given to me is hypothesis generation and planning a study. And this is the disclaimer as required by Pfizer. So this is the schema that I'll try and cover over the next 30 minutes or so. Additionally, I think a lot of the non-oncology setup in terms of asking a question was covered in the earlier session. I will be primarily speaking on conducting clinical studies and asking questions in a clinical scenario in the oncology setup in India, because that is where my experience lies. I will also not be stats heavy because I think there are far greater experts in the current CME and panel who will be able to take these up. And I will also briefly touch upon some of the logistic issues that a clinical investigator will face when conducting a trial in the Indian scenario. What I will be doing is going through four studies, three of which are studies that I have conducted or I'm conducting, and one which is a very well-known study, and see how the process of generating a hypothesis which is relevant to our scenario, and what happened finally, the lacunae, and so on and so forth. So the first scenario that I will take is a study that our group had published a few months back, where we evaluated sorafenib with metformin and atorvastatin in advanced hepatocellular carcinomas. So as a background, till approximately 3 to 4 years back, sorafenib was the only available option as systemic treatment in advanced HCC. As clinicians, we all knew that the dose of sorafenib, which is 800 milligram, was not well tolerated. Majority of our patients required lower doses, and there is some data to suggest that even lower doses work just as well. This we had looked at in a small study at our own center and said that 45% of patients cannot tolerate 800 milligram per day. Now the question is, what can we do to improve outcomes, but also make it cost effective? So when we did a literature search, we found that metformin and atorvastatin, which are used in the management of diabetes and hypercholesterolemia, have some action in HCC, as well as having some action in chronic liver disease. They also sensitize the sorafenib against HCC. Plus, they are inexpensive. So our question was, how do we evaluate sorafenib with atorvastatin and metformin in advanced HCC? Is it relevant to the Indian scenario? And yes, we see approximately 80 to 120 patients per year in Tata alone, patients with advanced HCC who are feasible for systemic therapy. So it is definitely relevant in our scenario. The design, obviously, since it's a new combination, would be a phase 1 or a modified phase 1, and the sample size would be based on that. Now, our questions were twofold. One, how do we combine these three drugs? And two, we did not want to adopt a design where we would be increasing doses of sorafenib because it's not well tolerated. Instead, we wanted to adopt a design where we would actually decrease the doses of sorafenib and see whether this combination works. So when we did a literature search, we found this very old paper, which was published in 2005. And this was conducted with a drug called simaxinib, where they used changes in tumor perfusion as well as microvessel density to find out whether de-escalating doses of this particular drug could be useful. So they had already identified the maximum tolerated dose of this drug and then started bringing down the dose based on certain set criteria, which I had mentioned. So using this design as a base, we adopted it to serve our purpose. So what we did was, in patients who satisfy the inclusion and exclusion criteria, we started all patients with sorafenib full dose, atorvastatin and metformin. That was 10 patients at this level. And then if a certain proportion of patients achieved a response or stable disease or did not have greater than a pre-specified adverse event criteria, we came down on the dose. So the idea was that we would go from 800 to 600 to 400 and 200 of sorafenib while keeping the doses of atorvastatin and metformin static. So this allowed us to, identify our question that we will combine sorafenib, atorvastatin, metformin with de-escalating doses of sorafenib. It would be a modified phase 1 dose de-escalation design, and the sample size was anywhere between 10 to 40, which we would only know as we went through each phase of the study. Of course, I won't go into the results because that is not what I intend to show. But the idea is that in phase 1 studies, you do not necessarily have to go with the standard 3+3 design or the Fibonacci design. You can modify phase 1 trials to suit your needs and convenience as long as it makes sense. The second scenario that I will highlight is again a study that we had conducted at Tata, where we looked at a combination called CAPE-ID in advanced gallbladder cancers. So as a background, gallbladder cancers are very common in India. They are commoner in India than a lot of parts of the world. So they are a group of diseases where you need answers from in our scenario. The standard chemo is gemcitabine and platinum, and this has been shown approximately 10 years back to be the best possible treatment option. However, post this treatment regimen, there is no single standard that was established when we looked at this trial, at this scenario. A number of people used a number of regimens, and this included commonly used combinations like FOLFOX, S1, irinotecan, and CAPE-ID. What we were doing at Tata is something what the rest of the world was doing at that time. We took one regimen and used that in all our patients, and this was called CAPE-ID. And we saw that it was reasonably tolerable, it had reasonable efficacy, and we had a 6-month OS of 70%. So our questions were, how do we evaluate CAPE-ID prospectively? Of course, it is relevant to our scenario because it's a common cancer in India. What is the design that we should use, and what would the sample size be? So the two major questions when we were designing this trial was, what would be the comparator arm for CAPE-ID? Now, in an ideal world where you had enough resources for follow-up, patients would follow up, you probably could say that when you don't have a proven intervention, the best comparator should be best supportive care. But we were not confident that in our scenario, we would be able to follow up patients accurately once they were on the best supportive care arm. Secondly, in clinical practice, a patient with an ECOG PS of 0 or 1, would you be convinced that this patient should be offered best supportive care? In clinical practice, you would give that patient some treatment. So keeping these 2 points in mind, we said that we will take another chemotherapy arm, which in this case was irinotecan, as the comparator arm. The next question is, what should be the design of the study? Since prospective data with this regimen was not available, all options were on the table. It could be a single arm phase 2 study, it could be a randomized phase 2 study, or a randomized phase 3 study. Now, we rejected the single arm phase 2 study because the regimen of CAPE-ID has been used in multiple cancers across decades with a known safety profile. And we had a background already from our own institution as to what the expected survivals were. The next question was, should we do a phase 2 or a phase 3? Now, from a logistic point of view, the thing to understand is that patients with gallbladder cancer post initial therapy are a very fragile cohort of patients. So our idea was to get some kind of signal with a small trial and then take it from there if we had required a phase 3 or not. So what we did was, we said that we will compare CAPE-ID with irinotecan, We will use a phase 2 superiority design, and our sample size was, sorry, my mistake, yeah, and our sample size was 98. So we had estimated that KPID would have an expected 6-month OS of 70%. With monotherapy, it would be 55%, and that 15% difference with a 80% power and 10% alpha with phase 2 design would entail a sample size of 98 patients. And that helped us answer our 4 questions as to how to go about this study. The third scenario that I'll take is a very well-known study that was published in 2018 by my colleagues in treating head and neck cancers, was the weekly versus 3-weekly cisplatin as chemoradiation in head and neck cancers. As a background, the standard as concurrent chemoradiation is cisplatin 3-weekly. But there were perceived issues with tolerance, side effects, and completion, and hence in India, as well as across the world, a lot of people used weekly cisplatin, which was better tolerated, but we actually did not have any prospective evidence to suggest whether it was equal in terms of oncological outcomes. So the question here was, how do we compare weekly and 3-weekly? Is it relevant to our scenario? Yes, because we see a lot of oral cavity cancers. What is the appropriate design? Should you say that weekly is just non-inferior to 3-weekly, or is 3-weekly superior? And what would the sample size be? The key questions are, as I said earlier, the design. Now, there was no prospective study prior to this, or there were no large prospective studies. You could have said that, yes, 3-weekly cisplatin is superior to weekly cisplatin, but that would not answer the question as to whether weekly is not non-inferior while maintaining a tolerable side effect profile. The other important component of the study, which the investigators had to decide upon, was you can use concurrent cisplatin and radiotherapy in 2 scenarios. One, in patients who cannot undergo surgery, or in the scenario where they've undergone surgery and require chemoradiation. So the question the investigators would have to face is, do you include either one of the 2 or both of the above? Now, the investigators very prudently took both settings. In an ideal world, you would probably want to do a trial in both settings individually. But you have to realize that conducting a trial of this nature and 2 parallel trials would extend the duration of the study far more than what the investigators initially planned. The investigators in their publication have also said that they evaluated results earlier than expected because of the time taken. So it was a very prudent call on their part to take both settings so that the question could be answered. They ended up doing a non-inferiority study where the non-inferiority margin was 15%, and they ended up with a sample size of 300 patients. So, with that, they answered all the 4 questions that, we keep in mind when planning a study or, generating a hypothesis. Now, this is a table which I have shown to highlight a few points of the last 3 scenarios that I had discussed. It is important that, we keep relevance in mind when designing a clinical trial. For example, the phase 1 study that we envisaged in 2018, we were able to complete only and publish in 2022. By that time, sorafenib was no longer one of the preferred treatment choices in advanced HCC. The entire scenario was taken over by immunotherapy and other drugs. So while the process of the study is important, we don't know whether we will be able to take this idea forward in terms of applicability. So obviously, it was only hypothesis generating, practice changing. It was not practice changing or practice modifying. And that is something you got to be prepared for if your studies take too much time, because they may lose relevance with upcoming developments. The second study, the phase 2 study, again, the results were that, using 2 agents was not superior to a single agent. Was it practice changing? Possibly not. Was it practice modifying? Yes, because now it would give investigators a lot of confidence that you need not use two drugs. One drug is also enough. In a scenario where a majority of your patients have are very fragile and may not tolerate stronger regimens. The third study, if you look at it in terms of perspective, sorry, was it practice changing? Maybe. Was it practice modifying? Definitely. Because even though it showed that the weekly regimen was not non-inferior to 3 weekly, it definitely gave treating clinicians two important points to take home. One, when possible, give a 3 weekly. When not possible, you may give weekly regimens, and you have some data to support the same in terms of outcomes and tolerance. The point I want to highlight here is that even if you plan a study with the best intents and the correct hypothesis, not all of them will be practice changing. Not all of them will be relevant by the time you publish the final results. So that's something you got to keep in mind. The final scenario that I will be talking about is a trial that we are conducting at TMH. It's an ongoing study, and so this is with regard to ampullary cancers. Now, ampullary cancers are very rare, and the in that location, the tumor that you concentrate more upon, where there is far more data, is pancreatic cancers. But ampullary cancers are supposed to have a different biology and are considered rarer. Now they are divided into two subtypes, intestinal types and pancreatobiliary types, and there is some evidence to suggest that the intestinal types probably do better in terms of survival. Even though they are rare, there is data from our own hospital that operated patients, almost 70% of patients who undergo a pancreatic surgery, their primary is a periampullary tumor. So even if it is a rare tumor, at least in our scenario, it appears commoner. So there is something there worth looking into. Now, there are no guidelines for what you give in patients post-resection. There are very few randomized trials in this setting. Some clinicians treat it as pancreatic cancers. Some clinicians say there is no benefit for giving further chemo after surgery. They observe. The common practice is to give gemcitabine for 6 months. Now, the questions that we had were, one, how do we evaluate histology-based treatment of ampullary cancers? That was the question that intrigued us. It is commoner than pancreatic cancers, but not that common. So we had to design and have a sample size that we could complete in our scenario. So these were the questions that we were facing. So what we did after a lot of thought is that we designed an adaptive design phase 2 trial. So what we did was essentially running two trials in one. Patients who were diagnosed with a pancreatobiliary type tumor, they were compared, we made the sample size such that improvements in survival were compared to historical cohorts. The same thing was done for the intestinal type. We had data from our own institution on how these two subtypes performed. We looked at available data from outside and then decided to run a parallel non-randomized trial where both cohorts, even though in one trial, would be evaluated separately. So this is what I was saying, that sample sizes were calculated separately, but the whole trial would be conducted under one ambit. And for the pancreatobiliary cohort, we were expecting a 2-year RFS with gemcitabine of 60%, and to improve it to 75, we would need approximately 67 patients. Similarly, for the intestinal type cohort, our historical data said that the recurrence-free survival was 75%, and we wanted to improve it to 85% with histology-based treatment with KPOX, and that would require 126 patients. So, we answered a majority of our questions in generating the hypothesis. The only thing that, we still have to keep in mind is that this is a rare cancer. We have planned a trial for 5 years. We probably are going to overshoot that because of, it's not as common. And yeah, so those were the 4 scenarios that I wanted to highlight. And the last scenario especially is primarily to say that the patterns for phase 3 trials are largely set. But in phase 1 and phase 2 trials, you can mix and match. You can think out of the box in terms of sample size estimations, designs, and generating a hypothesis to suit your needs and scenarios. The last part of my talk deals with logistic issues and you know irrespective of the ideas that we may have in conduct of clinical trials or the questions that we want answered, the key in India is logistics, logistics, and logistics. These are some of the things that comprise these logistic elements, and I'll briefly cover some of them. The first thing that we must know is that there is a difference in how investigator initiated academic studies and sponsored pharmaceutical studies are run um, and evaluated. The key for the investigator initiated studies is that this is the way that clinicians get prominence in the field, and by which the institution also achieve prominence. And the key is publication of this data. When it comes to sponsored studies, the degree of evaluation is far more, scrutiny is higher. There is a need for them to preserve the investment in their assets. And, the idea is that the drug could be developed for future use or not. And essentially, it is not an institution or a PI, but an entire study group that is credited when this is published. When you add on to this, in a sponsored study, you will have these many people who will be part of the study. You'll have a CRA, you'll have a CRO, you'll have a coordinator, you'll have a data manager, you'll have a biostatistician. When it comes to investigator-initiated academic trials, this is what you get in India. It's you who is the clinical research investigator. You might have a study coordinator, and you might have, and you will have the institution ethics committee, which will conduct audits of your study. But by and large, it is a very small team who is going to conduct this entire research. And all the points I have listed on the left, funding, regulatory burden, is essentially done by a very small group of people, which is headed by the PI. And if you are in an academic setup, you're going to be not conducting one such study, but multiple such studies. And this places a significant burden on you, in the Indian scenario. I'll tell you why. Because this is data which was published in IGMPO around 2 to 3 years back, where they compared the workload for medical oncologists, at least in India. Now, as you can see here, clinical duties take up around 70% of time for oncologists in India. It is important to note that unlike in the US, where investigators get protected time and are paid for protected time to conduct research, in India, whatever time you spend on research is above and beyond your routine clinical work. And the routine clinical work occupies a lot of time because of the volumes of patients that we have. So when you're conducting a study or when you're conducting studies, you need to be sure that you're able to carry these studies out, because they place a tremendous burden on your time and resources. The other important thing that when it comes to logistics is, good staff. Now, this is data from clinicaltrials.org, which says that, there are, as of 2019, in 200 countries, there were almost 260,000 registered studies, and the maximum number of studies are from oncology. Now, this also means that the number of support staff, CRA, CRO, should be increasing. Apparently not. So there are multiple editorials in multiple magazines and journals which have said that while the amount of research that is being conducted is increasing, you're having a severe, significant shortage of clinical research or good clinical research personnel to support these studies. Because in investigator-initiated studies or sponsored studies, you need to have very good support personnel, or else that the lack or presence of the staff can make or break your study. Even more importantly, assuming you get a good trained staff, who's going to pay them? This is just a snapshot of the salaries based on the information I could gather around 6 to 8 months back. When you're planning a clinical trial, you need to account for funding for good staff. And this is some of the funding and salary requirements for a CRA, study nurses, and a biostatistician. If you have a study of, let's say, 5 to 6 years, you need to envisage this amount of money towards your support staff and their salaries. Now, why is this important? Why does this all add up? Because of funding. I have listed some of the common sources of funding in India, and the good thing is that almost 44% of funding for research in India is via the government. So, which is quite welcome. And the ICMR, the DBT, DST do fund a fair amount of research, including oncology as well. But to give you a perspective, I'd like you to concentrate on the box in red. So this is data from DBT, where this was a document they had released in last year, where they said that they had spent close to 240 crores over 10 years for oncology alone. Now, 240 crores is a fair amount. But if you look at the top two graphs, you will clearly be able to notice that a majority of the funding from DBT, DST goes to basic medical research and not to clinical research. So if you're into clinical research, assuming that the number below of 240 crores, you divide it by 10, so that's 24 crores a year, and then you remove 75%. So essentially, all the clinical investigators in the country are going to be under the ambit of 6 crores per year. They're going to be competing for just 6 crores per year, and we know the costs involved with doing clinical research. So while organizations like DBT, DST, and ICMR do fund projects, we got to realize that a lot of it is not for clinical research, but for basic research. And the funds for you need to keep this in mind when you're planning your studies. This is a paper that was written around 7-8 years back. For those interested, you can look through it. It gave a snapshot of how cancer research was conducted in India. So to conclude, and it's not a conclusion, but it's more points to ponder. Research in the clinical aspects of oncology is at a nascent stage, but it's growing, and it's required to a greater extent than we recognize. Identifying the research question is the first step, but that is not enough. It has to be relevant to the Indian scenario. However, even if it is correct and relevant, is it feasible? Do you have the funding? Do you have the support staff? What is the duration that you're going to take to complete the study? Another thing that we should realize is that not all studies have to be high impact. I mean, we can start small by answering small questions, but relevant questions. Do not underestimate the need for good support staff, nursing, lab. The lack of these can make or break your study, and you have to account for good staff. Funding is relatively scarce and highly competitive in India. Please keep this in mind when you're planning studies. It's important to note that clinical research in oncology in India is very, very labor intensive. You do not get protected time. You're going to be spending more time than you're going to be spending time beyond your clinical time, and this might take a toll on you. So plan your time accordingly when planning studies or the number of studies that you can take on. With that, thank you, and I'd like to thank the audience and the organizers for your kind attention.